to infinity and beyond, basically the brain. There's so much of the brain that we just really, as physicians and medical providers, that we just do not know. They say that we use roughly 15 to 20% of our brain. So there's of it that is out there that we can keep going. All right. So how many squares do you see? Over 25. What? Okay. So over 25, got a lot. All right. Well, the biggest thing is that it matter in the aspect of how many there's actually are there. The biggest is really how many you see. So there's so much that we do in EMS and perspective is really your perspective. So when we get down into the anatomy, or actually into the assessment portion of the neuro, I have this in here. It's really for the aspect. It's your assessment. How do you do it? Okay? As long as you do it the same every time, it doesn't matter, just as long as you get it done. When you hear hooves, think of horses. This is a quote that's been told to me many of times. But sometimes you've got to think of the zebras. There you go. And then on occasion, you do have to think about the color or the pink zebra. All right? So think of hooves, think of horses. So occasionally you get the zebra, and then it's that colored or the multi-pink and all that stuff. And that's really the oddball when we get into the medicine that we just don't know about. Like everything else I really do, we always start off with a little bit of anatomy, a little bit of physiology. So you think about the nervous system's broken into two parts. You got a central nervous system, which is the brain and the spinal cord, and then the peripheral nervous system, which is all the external nerves. All right. The spine is protected, of course. The brain is protected in the skull, the calvarium, and all that stuff. The spine is protected by the vertebrae that's going down. And at what level, where does the spinal cord stop? At the butt. Okay, where specifically? What level does it stop at? Actually, it stops higher up. What? Lower lumbar. Nope, keep going up. The actual spinal cord, it stops at, the lower thoracic, upper lumbar. So T12, L1, L2, that region. That's where the conus medullaris is. Everything from beyond that, the horses, or the cauda equina, which is called the horse's tail, that's the lower portion that goes through. It's still in the spinal column, but it's not technically part of the spinal cord. Peripheral nervous system, we have 43 nerves originating from the CNS. There's 12 in the thoracic. You'll have 8 in the cervical, 12 in the thoracic, 5 down in the spinal column or the lumbar region, both sides, and maps out from there. Spinal nerves and all that stuff. The nerve system, again, going up top, you have the discussions back and forth, or the communication between the spinal cord and the brain. And then from there, you'll have from the cranial nerves, the 12 cranial nerves. If you don't remember those, that's on an old Olympia, Tiny Tops, a fit in German, viewed some hops. If you've never learned the cranial nerves, it might be a good idea, because part of doing your neural assessment is knowing the cranial nerves. All right? And we'll briefly go through that stuff, not much. Spinal cord and all that stuff talks with the spinal nerves. And then between the cranial nerves and spinal nerves, you have the autonomic system, which is the involuntary. This is the control, your breathing, your heart rate, your digestive system, all that stuff, okay? If you're a blonde or something like that and you're trying to control your breathing, you would die. It's that one blonde joke. All right, versus the somatic, which is the voluntary or your motor nerves. We control how our arms move, except at nighttime when we do the involuntary twitching and all that stuff. And then, of course, the final portion of it is your sensory nerves. Inside the calvarium or the skull, we have three different things. You have the brain itself, you got the blood, and then you got the cerebral spinal fluid or the water. All right, that's going to be your oil, lube for just like the motor engine, all that stuff. Brain's mostly water. It's like 85% water. And then from there, the blood coming in, three major branches. You have the carotids coming up, and then you have from the back of the brain, you got two vertebrals that come together to form the basilar artery. Those are predominantly the three major branches of the arteries coming into the brain itself. And then you have multiple capillaries, sinuses, and all that stuff. The cortical veins and the dural sinuses. And once again, all the sinuses is a collection of blood, just like we have in the heart. All right, so located in the ventricles, cerebral spinal fluid, and then all the extracellular and intracellular fluid. That's predominantly where all the water is located. The brain itself, made up of different lobes, actually has different parts. First of all, the cerebrum. If you think of Professor X and all that stuff, you have the four different parts of the cerebrum. The frontal lobe, this is predominantly our thinking portion of it. The parietal and temporal lobes are getting into the sensory and emotional sides. And then the occipital is more the vision, where that's the major neurons and all that stuff are located in the occipital. The pons, medulla, and then the spinal cord. The pons are the brainstem. These are the control centers for the majority of the autonomic system. Our primitive reflexes live there. So if we kill off the cerebrum, we can still survive because of the brainstem. And the cerebellum is the location of our ability to coordinate. So if you think about the brain, left and right, it's actually, this is a CT representation. So the right side is actually on the left side is actually on the right. So the left side of the brain is all of your touchy-feely, lovey stuff, versus the right side of the brain is our math and are you right-brained or left-brained, depending on all that stuff. Some people are both, not like me. All right. Functions. Again, this is going to be the temporal lobe right here, the frontal, the parietal, and then the occipital. Just looking at that. Two different fissures, and a fissure is just a place that separates the lobes themselves. So the lateral fissure, and then the central. The central fissure is a major one because it actually splits the premotor cortex versus the presensory cortex. On the next slide, we'll talk about the homunculus, or the little man, and the little man sits right in this area. The lateral fissure, this is your Broca's on the left side, Broca's in, which is your speech, and then the Wernicke's and all that stuff for the Broca's and the Wernicke's, which are your speech and your hearing locations. All right. So the homunculus of the little man, I don't know if you guys ever seen this before. Most people aren't. So if we split the brain front back, basically how our nerves and our bodies feel things. Our feet sort of hang over on the inside, the middle portion of it. So we have, excuse me, little feet, small legs, small arms, big hands, okay, because that's really for sensation and movement. A lot of that. A lot of sensation and movement in the face. We can pretty much touch and taste and smell and all that stuff, which is on the more the lateral aspect, and of course, big mouth for some people. And then the last piece is actually the genitalia. So big penis and vagina for sensations and all that stuff. All right, a lot of sensation, a lot of movement and all that stuff down there. So pretty much the biggest when we get into the neurologic stuff, it's really affecting of blood flow. Okay, so if we stop blood flow to the brain, that's where most of the damage is, either through hemorrhage, through blood clots, and all that stuff, which we'll talk to in a little bit. So structural damage can have problems. We can have circulatory changes, the clots, and all that stuff. Increased ICP. I take a baseball bat and smack you in the head. You're going to have some, just like a punch in the arm, it swells. That's where the ICP increases and all that stuff. And then we lead to the two pieces of controlling, and this will be pretty much the last of the neuroanatomy review. So for those, it's quickly through all that stuff. So the two things that we kind of sort of control the neuro with are the two neurohormones are glutamate and GABA. GABA is the gamma-aminobutyric acid. GABA is the stop. All right. So if you want to, in some of the chemicals that we give to some patients to calm them down, kind of sort of affects GABA. So GABA is the inhibitory, which is actually everything, and then glutamate is the excitatory side. It revs everybody up. All right. Questions on any of that? All right. And then, of course, they both work together for the brain control. So what is mentation? Definition of mentation. Oh, we do it all the time, and we assess someone's status. So what are we doing when we assess someone's mental status? Establishing, okay, they're alert. All right. And what does that mean? Okay, aware of their surroundings. Are they, yep, memory? Thank you, ma'am. Yeah, thank you. All right, so surroundings, all that stuff. Memory. Shush. I need nothing from the peanut gallery. All right. So basically, we need to, in understanding normal, we need to know what abnormal is, and that's really the biggest. Practice means different ways of identifying mental status. Glasgow Coma Scale. Talk about it a little bit. Are they oriented? Person, place, time. Some people add a fourth one, which is the, why are they there? Do we understand that? AVPU. What's AVPU stand for? Okay. So what is AVPU really checking? Yep. Level consciousness. All right. So different ways to really look at mental status. And what you guys talked about is, of course, that's the big thing. Is really the mental status is, do they understand what's going on? Do they know who they are? Are they aware of their surroundings? Can they actually function in their surroundings and all that stuff? So when we look about abnormalities, many different lists. I always like using the AEIOU-TIPS, and that's what we're going to kind of sort of go through. And then from there, but always think about outside the box. And that's why I kind of sort of had at the beginning, how many boxes out there. Because each person is going to kind of sort of think, a different perspective. And, it could be that. It could be, something like that. Mino, Mino, Mino. All right. So in the past, I've always gone through and done anatomy, and then I would do disease, and then I kind of sort of went through um, the treatments and or assessments and all that stuff. But this one, I kind of sort of changed around because I want you guys to be thinking when AIO tips in a little bit of what's wrong in the assessment or how do we do the assessment side of it. So we're going to go through assessment, kind of sort of some of the treatments, and then go into the pathophysiology of all that stuff. So of course, first thing, anything that you always do, make sure your BSI is seen safe. You know, wear your gloves, wear your goggles, all your protective PPE stuff. You know, you guys probably been seeing a lot out there with the Ebola scares. Actually, had another potential case yesterday. So just on that aspect. First and foremost, don't forget your ABCs. Okay, everything starts with the ABCs, and then from there, BLS and ACLS, everything goes from that. And then I'm going to talk about the 30-second exam versus the 3-minute exam. Okay, it's really depending on how much time do you have to be able to take care of things. First off, general appearance. All right, this is, if you guys remember, got to the pediatric triangle, assessment triangle, ABCs of the pediatric assessment triangle: appearance, breathing, circulation, okay, that side of it. All right. So look at the person. How do they look? Are they well groomed? Are they disheveled? So much of like your schizophrenics and all that stuff, you can tell how well they're acting just by their appearance. Observe the verbal and non-behaviorals. You know, they slumped over, they smacking an arm, stuff like that. Look at the facial expressions, their tones, volumes, speech patterns, eye contact. Are they looking at you and all that? And then from there is the memory intact. From that aspect, then it's really getting into the next piece of the actual assessment side. ABCs, of course, there's different things with that. Air, breathing, circulation. Do you need to control the C-spine? So many of the accidents, falls, stuff like that, where there are neurologic problems. Can the patient protect their own airway? What's a good way to test they have a patent airway? Can they talk? Yep. So they can't talk. What's another good way? Okay. Breathing. All right. What else? What reflex do we want to check for? Gag. How do we check for gag? No. What? Put an oral airway in, tongue blade, yank out. Some people with dirty minds. Okay. Put put the finger. That's fine. All right. And then from there, do they have proper ventilation, breathing, and all that stuff? And do they need supplementation? So airway open mouth clear, make sure that they have a patent airway. GCS less than 8 intubate. You guys as EMTs can't. Advanced EMTs can't. From that aspect, and then from there, absence of indications, always defer plastic to not having an airway. So put something in there. Check blood sugars and all that stuff. Opioid toxicities. Breathing, oxygen, high concentration with your decreased LOCs, and then of course assess respiratory rate, tidal volume. What's tidal volume? Yep, amount of inspiratory. Yep, how much we actually breathe in. So if you think about it, it's between 5 and 10 mLs per kg is how much tidal volume we actually take. or breathe in. It varies. And then circulation, pulses, and perfusion. Okay, and what is perfusion? Because we talk about it all the time: cerebral perfusion, perfusing the kidneys, perfusing the heart. Yeah, it's the amount of blood that those organs actually see. Okay, and on a mean arterial pressure, what's the ideal mean arterial pressure for a patient? So if you do the calculation, twice diastolic plus systolic divided by diastolic, you should get a number. Yes. 10 o'clock. So the mean arterial pressure is about what? 65. 60, 65 millimeters of mercury. All right. So if you look on your monitor, if you have the monitor on and all that stuff, it gives you your systolic and diastolic, and then sometimes they'll give you a number in parentheses. Some of them on, some of them don't. I'll make looks. All right, we'll talk about that later. I guess I need to include that one back into when we do the shock again in the future. All right. So patient assessment. Of course, always make sure you adequate circulation. What's the blood pressure? Does the blood pressure equate with how the patient have a real high blood pressure, but they're gorked out? Are they having a stroke or something like that? Do they have pulses? And then, of course, pulse rate and quality. Okay, so if they have a shallow, weak pulse, thready pulse, or if they have a regular pulse, absent pulse on one arm. Okay, let's say they're missing a pulse on the left side, and they're unresponsive. What's the potential problem? Might have a blood clot. What else? So something that you don't see that often, it's where you have neurologic problems with absent pulse. They're having an aortic dissection. It actually goes backwards, dissects into the arch, and it knocks off the blood supply to the brain. Do they need IVs? And then from there, is the access necessary? Do they need any precautions and all that stuff? Cardiac monitor for those that can apply it. Are they having any dysrhythmias? Are they in AFib? Are they in VTAC? We see a lot of times in VFib. Okay. We know patients that pass out and in VFib. Hey. Okay. What's the blood sugar? Okay. Nothing worse than potentially giving a patient TPA with a blood sugar of 38. That's a bad thing. It's happened on many occasions. So always check the blood sugar. That's really the first thing that we should be assessing. Do they require ventilation? And then from there, any of the history. All right. And what's the typical history that we take? What? Your sample. Okay. What's your sample history? Pertinent past. And the L is last oral and then eventually. Okay. Just got to make sure that we're remembering. All right. So either from patient, by the caregivers, bystanders, and all that stuff. A lot of times, if they're stroking out, the patient might not be able to talk to you. You might have to talk to OOBS and ask them. From there, any of the history of the present illness, pertinent past medical is always important. All right. So after we get the ABCs, all right, now we've gone through the sample history. and you can be looking at your 30-second versus 3-minute assessment. Actually got the sample history if you just remember that. Allergies, current medications, drugs abuse, you know, did they fall, any comas, witnesses, and all that stuff. So starting off, physical exam. Always remember vital signs. Vital signs are important. That's why they called vital. Okay? A complete set of vital signs should be documented. Okay? Per the new EMS guidelines in tab 1. Okay? Initial blood pressure, how should it be obtained? Manual. Initial pulse, how should it be attained? Manual. Okay? From there, always do your hands assessment head to toe. If that's how we're all traditionally taught, it doesn't matter. I don't really care. Again, your assessment, do it your way, same way every time. Listening, minimum, at least listen to minimum heart, lungs, and your neurologic exam and all that stuff. Do they have new murmurs? Do they have wet lung sounds? And all these things kind of sort of leads into the ultimate patients. From then, the neurologic exam, which we'll talk about, which will be the 30-second or the 3-minute. And then on the skin exam, are they having any rashes or evidence of infections or anything like that? A lot of that will sometimes lead to a patient's being altered. Don't know how often I have a altered old female that has a cellulitis. So there's reasons and all that stuff. The 30-second, okay, look at the patient. That's the first part, like everything else. It's that quote-unquote door. When you walk in, what do they look at? Notice a little consciousness. How are they breathing? How are they sitting? And all that stuff. From there, what's the 2 potential ways that we can assess for level of consciousness? Okay. So, and all that stuff is, what's the little mnemonic? AVPU. All right. So we can do AVPU. Okay. Other way that we can do for glaucoma. Okay. And of course, always ask for, are they alert and oriented and all that stuff. And then also the event. So what's the 3 parts of the glaucoma scale? Motor, verbal, eyes. Correct? All right. So score of 3 to 15. Remember, even a rock gets a 3. Okay. Which means that everyone at least gets a 1. That's the most that you. That's the lowest that you can get. More important, it's not so much one score, but the trend. Come up, they do it. They were 15, and then a half an hour later, they're now down to a 10. Guess what? That's a bad sign. Okay, or vice versa. If they were a 10 and now they're a 15, good. Just remind here, eye, verbal, motor. I remember. That's how I remember from head to toe. Eyes, you get 4. Verbal, you get potential of 5. Movement, you get 6. So spontaneous eye opening, you get a 4. Verbal stimuli. So if I come up and say, hey, Mike, wake up. Okay, you wake up, you get a 3 for that. And if I had to pinch on you, you get a 2. If you don't do anything eye opening at all, you get a 1. Verbal, you know exactly where you are. You're alert oriented and all that stuff. You get a 5. If you're confused, you don't know where you are, which is traditionally the most common. You lose where you are first. You lose what the date is next, and you lose who you are last. Okay? Confused, if you're saying inappropriate words, you get a 3. You're shouting an F word every now and then, but nothing else. Or if you get the incomprehensible sounds, that we've all seen before. All right, get a 2. Motor, obey, get a 6. Localized to pain. Basically, I pinch your nipple and you kind of sort of grab my hand. Okay, that's localizing. Okay, if I pinch your nipples. All right, if I pinch your nipple and you push away, you get the 4, and then of course the abnormal flexion and extension when we get into the decorticate or the decerebrate posturing. All right. Corticate is the abnormal flexion, decorticate or the cerebit is your abnormal extension. What? Yeah. All right. So 13 to 15 is just mild brain. 9 to 12 is more of a moderate. Less than 8, of course, severe brain. Patients in comas, and they need plastic. Okay. Remember, less than 8, intubate. The exam. All right. This is the 30-second sort of quick. I need to know if I'm going to stay and play or if I'm going to load and go. All right. So ask them. First question, how you doing? Okay. If they answer you, what do you know? They have an open airway, they're conscious, and they have a pulse. All right. So we at least know those 3 things if they can answer you. Well, Matt, yeah, conscious would not be, they might not be oriented. Okay. So from there, still looking at them, I have them smile. Okay. You can get the quick from the aspect of facial imagery, and then have them say something. I don't care what it is. Blue sky over Cincinnati, over Toledo. I like using the term, have them say no ifs, ands, or buts. All right. That term, you have to really use your tongue and articulate to be able to get all those words out. Look at their pupils. All right. Do they have pupil asymmetry? 1 millimeter, patients can have a 1 millimeter asymmetry, and that's normal. When you start getting more than 2 millimeters, then that gets into the abnormality. Have them squeeze fingers, let go of the fingers. Sometimes they'll grab because it's a natural reflex. Okay, babies will grab your hand naturally. Let go. Have them lift up a leg, push on the gas pedal or the brake. All right. And then the pronator drift. Lift the hands up, turn your hands over, have them close their eyes, and basically you'll just see one arm slowly drift down. That's what the pronator drift is. Yeah. Well, ideally you want to turn them, palms up, because if you just have them there, they can drop down, which is still a positive. But you'll get some patients, they'll just do the bit of, if the palm up, all that you'll see is they'll turn the palm over. It helps enhance or make it a more specific exam, or more sensitive exam. Is it necessary? No, but it just helps out. All right, 30 seconds. You can do that in 30 seconds. Any abnormality there? What should we do? Go. All right. So the other piece of that, just remember the fast, everything that they're talking about. You got billboards all over the place with this. Fast, stroke, fast, stroke, fast. They're saying, the facial droop, arm drift, speech, and then time. All right. If there's not anything for you guys in the EMS arena, if the only piece of history of the patient is having a stroke or something like that, if you got nothing more, getting in the family, when did this start? If you gave me nothing more, I would be quite happy. Just facial droop, kind of sort of looking at, you'll see here a little bit. Sometimes it'll be sometimes so subtle that all it is just a loss of a little bit of the nasolabial fold. All right. From there, pronator drift, hands up, kind of sort of, they should be able to hold them up for 10 seconds at least. That's the same with the legs. They should be able to hold it up for 10 seconds. And then speech. You can't teach old dogs new trick, no ifs, ands, or buts. Really, I don't care. All right. Questions on that? Alrighty. It varies. It all depends on where the stroke is. Going back to the anatomy side of it, you could just have, right at knocking out, like Broca, so they can't talk. Everything else is working perfectly fine, but they can't talk. You can have it along the homunculus where they lose the sensation to the leg or something like that. So it really varies. And it depends on, again, what artery is being knocked out. Is it do they have blood going into the ventricles? Were they putting pressure on, having increased cerebral ICP, just because of having all the blood in the ventricles and all that stuff? Yeah, good question. All right, so in the 3-minute, this is really kind of sort of where you get to take a little bit more time to figure out potentially what's going on. I was talking with one of the nurses at St. Charles and also on Woodville, and we had, because he was asking me about subtle findings and all that stuff. And then half an hour later, we had a patient roll through St. Charles that had subtle findings and all that stuff. Kind of interesting. So looking at signs of a head injury, consciousness, cranial nerves, which we'll talk about a little bit more. Not a lot, but just kind of sort of go through, because it will give you an idea. Sensation, motor testing, cerebral functions, finger, nose, have them stand up, and the deep tendon reflexes, which I have to admit, I don't always do my deep tendon reflexes, just because I have so many other things that's going on. The way to start, always remember, level of consciousness, your AV-POO, same thing, just to kind of sort of reiterate on this. And then getting your GCS and document and remember, what you guys had abnormal. Head to toe exam, again, getting the aspect of cranial nerves, speech, talk, sensation of the face, muscle testing, open the eyes, closing, squeezing hands, moving arms. The cerebral functions, are they able to stand up? Can they walk? Can they stand on one leg? And then proprioception of the toes. And that's the one thing that I really hot on the residents, because so often they forget the test, toe up going or down going, which can tell just a lot by that. If you don't do anything on just looking at toes, can it tell the toes is the toe up going or down going? It tests the whole pathway from the foot to the brain, so which is a good thing. And then getting in the primitive reflex, the pupillary light, the corneals, the gags, the Babinskis, and the pronator drifts. Special testing. All right, that's really encompasses 3 minutes. It's long. It takes time to do this to get a real good exam. That's why I call it the 3 minutes. So in the cranial nerves, all right. So light response, 2 minutes. Cranial nerve 2. Basically shine a pen light in their eyes. Does the pupil constrict, open up? That's a test in the afferent and efferent pathways of the optic nerve. Extraocular movements are 3, 4, and 6. So the ocular, and then the for the lateral rectus. I'm blanking on 6 right now. Sensation to the face and clenching of the teeth is cranial nerve number 5. This is the one when this is the Bell's palsy, or part of the Bell's palsy can be affected here, where they can't clench their teeth. Smile, puff out the cheeks is cranial nerve number 7. And this is predominantly Bell's palsy with cranial nerve number 7. So one aspect, sometimes if you knock off, or you can kind of sort of tell the difference, if they can't lift their eyebrows one side, it's usually a cranial nerve 7 palsy versus something inside the brain. So if they can lift their eyebrows up, that means that they have innervations on both sides, which is usually more along the signs that they're actually having a stroke. Hearing, can they have problems? Gag reflexes is 9 and 10. And then raising the shoulders is 11. And then sticking the tongue out is 12. All right. And that. So shine a pen light. Have them look left, look right, look up, look down. Touch their face on the forehead, the middle of on their cheeks, and then on the bottom of their face. Puff the cheeks out, raise their eyebrows, close the eyebrow tight, Can you hear, both sides of the ears and all that stuff? Gag, shove something inside their mouth. Have them raise their shoulders. This is the major one that most people forget to do, is raising the shoulders. And then stick out the tongue. All right. Which nerve did I not talk about? One, which is olfactory. Do you have any abnormal smells? Technically, in order to test that, you got to pull out all the different, whole bunch of chemicals and all that stuff. So how would you document your cranial nerves? What would be the documentation piece? What? Feeler, feeler. Pupils, echo-round reactive, size, extraocular movements intact, meaning that they can look up, look right, look left. They have sensation. Okay. So often people will say, cranial nerves 2 through 12 intact. Just make sure if you're saying that you're testing all 2 through 12. Okay. Or a lot of times I go through each one. Okay. So pupils 3, brisk, equal, round. They can puff out their cheeks, smile, tongue midline, normal shoulder shrug, gag reflex intact, hearing without any difficulties. So mydriasis, or the dilated pupils, a lot of chemicals can do this. Pinpoint, or the meiosis. This is traditionally going to be heroin. Well, this mydriasis, a lot of time will be like your cocaine and all that stuff. Unequal pupils, and usually if they're unequal, they're noticeable when they're really unequal with head traumas and damage and all that stuff. Occasionally, it might be a little bit. And then, of course, you guys have the fixed and dilated and pupils and all that stuff, which is a very bad. And then the normal size pupils, which is usually between 3 and 4 millimeters. Yeah. Like, wow! Or the ones that are wearing the contacts. Yeah, I've seen that a couple times where they actually, I don't know why, they actually had the contact hole was bigger on one side than the other. So extraocular movements, of course, normal here. Looking to, if the patient can look to the right, the lateral rectus, the medial rectus, the superior rectus, or the inferior oblique. Superior oblique, inferior rectus, and then convergence, basically looking in, both medial rectus and all that stuff. So just every piece depending on which side of the eyes that you're looking at, and depends on which muscles and all that stuff. So if anything, at least have the patient look to the left, look to the right. So looking that way, you can tell if they have at least a third nerve palsy, because that's what medial rectus is looking at, number 6, or the cranial nerve number 6, which will be your lateral rectus. And then from there, looking up and looking down will be your 3 and 4. Working on those ones. All right. So look left, look right, huge. You can just tell just a simple cranial nerve number 6 palsy. Conjugate gaze. All right. Conjugate means that both eyes look at the same direction, okay, the same place. Versus the disconjugate, okay, the eyes are split. If you really want to see a good disconjugate gaze, find somebody that's really intoxicated, okay, that's out of it, and look at their eyes. They'll have a disconjugate gaze. So from there, we've done all the cranial nerves, looked at the eyes, did all the disconjugates, and then getting into the sensation and strength. Touch everything. Can they feel every part? Ideally, you should touch every dermatome, and you should assess every myotome in the body. Squeezing hands, pulling arms, pushing arms, raising shoulders, shrugging shoulder up, lifting leg up, extending the leg, pulling the foot towards you, pushing the foot down. Yeah. Squeeze fingers, open fingers, you know, thumbs up, you know, giving the 6-shooter, all that stuff, middle finger, whatever. Posturing, getting into the decorticate or decerebrate rigidity, which is really looking at abnormal flexor responses and all that stuff. One arm flexions, extensions, and this is really a damage to the cortical portion of on a decorticate posturing versus the decerebrate. On the decerebrate rigidity, this is a normal extension side of it, basically knocking off the brain, the legs extend out, the arms extend out, and all that stuff. And this, of course, is a worse prognosis, thought to be subcortical damage to the regions of the brain and all that stuff. And then getting into the flaccidity. This is usually destruction of either the brain stem or the cord. All right. So decorticate to the core, what they do is they flex their arms up and they bring it to midline, okay, because they're trying to protect themselves. So decorticate to the core. Decerebrate, extension of the arms out. They rotate the arms down, push it down, and for some reason on both of them, their feet both go into an extension pattern. I'm not sure why that. But it's really, you're looking at the hands. So they roll their arms out and then push their flex arms and stuff. Go more along the lines of, that's probably more into the corticate. If they're bringing anything up where they're, yeah. So, faking it, yeah. That would I'd go more along is probably he's having a decorticate posturing side of it, where they bring anything that brings the arms up to the core, anything like that, where they have an flexion of the arms. Primitive, okay. Pupillary light reflex, basically testing cranial nerves number 2 and 3, which goes from the afferent pathway to the efferent path. What you're doing is shine the light in one eye, and you should have constriction of both eyes. All right. Corneal reflex, if they're really out and not responding, you can take a piece of cotton, a Q-tip, whatever, and touch the eye. Okay. Literally, and then from there, person should blink. Okay. If they don't blink, that's a bad sign. So here we're testing cranial nerves number 5 and 7. So 5 is the sensation for the eyes, the cornea, and then 7 is the blink reflex. It's okay. We can take care of that later. All right. So on the gag, 9 and 10, 9 is going to be the sensation, 10 will be the axial reflex. Of course, from there you can always, if the patient's awake, kind of sort of have them say ah and look in the back of the throat. The uvula should go straight up. If the uvula goes to the left or the right, that's usually whatever side that it deviates to is the side of the lesion. And then the Babinskis or the plantar, where you, actually, if you've never seen it, come over and you can see it on my 3-month-old, where you stroke the bottom of the foot in an arc, the big toe should go down and the rest of the toes should splay out. Well, it's in anybody. Well, if they have the reflex, but as we get older, we lose the Babinski reflex. Ours, actually, one of those will curl down. So the big toe will go up, the dorsiflex, and the other little toes will fan out. Psychological side, because we a lot of times so much that we deal with on the neuro is some of the thought or behavioral side. Are they having logical, realistic thoughts, false beliefs, suicidal? Are they perseverating, hallucinating, anything like that? And then getting into the mood and effect, ask how they feel. And remember, asking somebody if they want to kill themselves does not imply that they're going to do it right then and there. All right? So you can ask them that. Insight judgment, do they understand what's going on? Sensorium intelligence. We know that everybody is the sharpest man in the box. And then cognition. All right. Questions on any of that? I hear you. Oh, here. All right. Yeah, it would be. We have to do margaritas, though. So always remember, level of consciousness thing that you need. Sugar, okay? We need sugar. The brain needs sugar. Oxygen. If it doesn't have oxygen, it doesn't do well, okay? It needs an intact neural pathway. And then what's called the reticular activating system. This is part of the midbrain. This gives our sensation or our awareness part of the brain. It works on histamine as the only function for the reticular activating system. So when we take Benadryl and we pass out because of taking Benadryl, why? Because you're actually inhibiting this pathway. Anything that disrupts it can cause alteration of mental status. Right. So on the blue, assess it, make sure that you're not having any of the second or third issues, on top of the hypoglycemic. All right. And always remember, pediatrics, you can give them some sugar, guess what? They're going to dump it again. All right. So they're real quick about burning up their sugars and all that stuff. Give them sugar if they need them. Give them oxygen for the hypoxia. Pinpoint pupils with what for you guys in the guidelines? Respiratory depression. Thank you, sir. Appreciate that. Give them the Narcan. Seizures for medics and all that stuff versus Valiums. Dextrose if they're hypoglycemic seizures. And then from there, if they're cold, warm them up. Slowly. Yes, correct. Other things, of course, if we can't do that, secure the airways. If we lost protective reflexes, immobilize them if need be. C spine, C collar, backboard, and all that stuff. If not thinking that, left lateral decubitus position. Oxygen, it's necessary. We need it to survive. Okay. Lack of oxygen is always a bad thing. From there, also look at monitoring the neurologic systems. So what's the difference between oxygenation and ventilation? Correct. Yep. So ventilation is the process of moving air in and out of the lungs. So we're getting rid of CO2 and bringing oxygen in, and then the oxygenation is the process of bringing oxygen in. Good job. Have a tidbit. All right. So an ultimental, this is kind of sort of where we're going to go down this pathway through AEIOU-TIPS. All this can have effects. Sugar problems, hypothermia, cold, respiratory problems. Do we have, if we're bleeding out, decreased blood problems, we know that. Medications can cause a lot of problems, in fact, dementias, heart problems, injuries, and all that stuff. So it's not really the aspect of diagnosing, okay? What you're looking at is kind of sort of what's the cause of the ultimental. We're really here. And then, can you fix it? Can you figure out what the cause is, and then can you fix it? Coma, basically just a state of unresponsiveness. A couple different parts that we'll talk about through. Coma, unconscious, immediate life threats. Really think about aspiration, loss of airway. Anything that you need to do to maintain the airway. Oral airway in, gag. If you can put if they're unresponsive, no pulse, not breathing, of course you guys can use the EMLTs or the LMAs. If they have a pulse but they're not breathing, ventilate for them. Call for ALS backup. The DERM, don't forget your 30-second survey with that. And then the DERM is another piece of looking at coma. Depth of the coma, which is getting into your AVPU and your GCS. Eyes, again, just to reiterate, do they have differences in eye sizes? Respiratory problems, which we won't talk that much about, but you can see different respiratory problems. Chain stoking, Kussmaul breathing, stuff like that. And then motor functions. Again, we've talked about this several times, your AVPU, your GCS. Okay. So what's the three parts of the GCS? Eyes, verbal, motor, okay. And how many points do you get for eyes? Verbal, motor, okay. Pupils, again, eyes, are they dilated, constricted, responsive to light, how they reacting, and all that stuff. Respiratory, unusual, shallow, deep, do they have altered pattern? This is, again, going into like your chain stoke, where you breathe, you'll breathe fast, faster, then you stop breathing. Or the Kussmaul breathing, which is like your diabetic patients, where they get that rapid, fast breathing. Pursed lip breathing in your COPD patients. Or pursed lip kind of sort of altered, what's a potential problem? So if they're altered and they're pursed lip breathing. So we know that pursed lip breathing is typically COPDs. So if they're altered and they have COPD. So CO2 level high or low? High. All right. Correct. So these patients, they have what's called hypercarbemia. So they have a real increased CO2 level. So this was the problem on Apollo 11 that they were worried about. They had a lot of oxygen, but they couldn't get rid of their CO2 levels. And that's kind of sort of high CO2 levels, you go unresponsive. Our cold, this is traditionally how most cold suffer from cold deaths. As they stop breathing, they get too cold, and then they build up their CO2. Motor functions, evidence of any paralysis, movement stimulations, pinching on their legs, pinching on the inner side of the arms, how they can actually move and all that stuff. All right. Possible causes. Again, just to reiterate, not enough oxygen, not enough sugar. Do they have damage? Or is there not enough blood flow? Everything really affects all that we're going to talk about when we get into the next slide with AEIOU-TIPS. It's this. If you don't remember anything else from the story here, okay, remember oxygen, sugar, blood flow. Pretty much you guys can take care of the rest. So the that I like using, okay, A for alcohol acidosis. Acidosis, what I talked about earlier, or just a couple seconds ago with the pH. Okay. E, endocrine electrolytes or encephalopathies. I for insulin. O for opiates. U for uremia. This is going to be your kidney failure patients. T for trauma, shock, all that stuff. The other T for trauma or tumor. The other I for infection. P for poisonings or psychiatric. Are they Munchausen or something along that line? And then F for any of your seizures, syncopes, strokes, and all that stuff. I left stroke off that. So alcohol, we know it's a depressant of the brain. Whole thing with that is we increase alcohol levels, they lose the ability, their judgment impairment becomes impaired, reasoning, everyone becomes louder, they have a lot of disinhibitions, problems with airway. We know a lot of good singers and all that stuff that have died because of vomiting and aspiration. Was actually there was a compilation disc. Intoxicated patients, they can go from stupor to coma to death, and it's usually all based upon the respiratory depression. All right. So GABA glutamate, which one's high, which one's low? GABA's high, glutamate's low. All right. So the brain and all the stuff is functioning going down. All right. Remember, GABA is the stop, the glutamate's the green go. Standard drinks, a can of beer has about 4%, a glass of wine is about 12%, a shot of vodka is 40, depending on which type of vodka you get. Tiki head, which I have no clue what that is. I guess that's the Hawaii Honolulu or something. Okay. Yeah. And then eating your rum truffles and all that stuff. 0.1%. Acidosis, many different things can cause it. Diabetes shock, where you get lactic acidosis. Metformin can cause lactic acidosis. Any of the poisonings, overdoses, kidney failures, and all that. Usually, a lot of times, this is where your diabetics is the most common that you guys are probably will be seeing. Endocrine, different causes. The endocrine system, which we talked about in the past, where this is acts like the nervous system. This is your hormones. What's the two major hormones in the endocrine system? For fight or flight? Epinephrine and norepinephrine. Okay. But many different endocrine systems and all that stuff. Chemical messengers, they travel in the blood, triggers response, and then a whole bunch of different conditions can cause that. Diabetes, low blood sugar, lack of insulin, thyroid disease, having problems with your TSH, free T-free, all that stuff, thyroxine and all that stuff. Obesity, when we get into your steroids, mineralocorticoids, glucocorticoids, and all that stuff. Electrolytes are a piece of the conductive system. What's the three major electrolytes of the body? Actually, four. If you're going to go one. So sodium, potassium, calcium, magnesium. All right. So we need sodium, potassium for the sodium potassium pumps to be able to move electricity. Calcium's for all the muscle contractions and all that stuff. And then magnesium helps with movements and part of the action potentials. So patients in torsades, which is your biphasic ventricular tachycardia, they'll go through and have low magnesium and all that stuff. And then chloride. Muscles, neurons, general kidneys functions is to get rid of all the excess electrolytes. Sometimes it can't do that. You can have different disturbances, dehydration and all that, where you increase your sodium levels. All the little patients that we get from the nursing homes that, they're not watered properly. They forget to flip them and feed them and water them. And that can lead to cardiac and neurologic complications. Encephalopathies is just a simple function. Brain function is altered, usually caused by different infections is the most common. Symptoms can include loss of cognitive, they don't understand, and then the personality changes. Brain infections, tumors, ICP increase, so your old elderly patient that kind of sort of fell a couple months ago and then now not acting themselves. They've had slow growing subdural hematoma. Or your alcoholic is another common person. Toxin exposures, radiation that we know that, and then going into poor nutrition, hypoxia, and then anything that causes decreased blood flow. So a lot of causes for encephalopathy. West Nile virus, this is one of the things that causes encephalopathy. Or watching Big Bang, the prions. Insulin has a problem. If we don't have insulin, we can't get sugar into the brain. And then from there, that's where the whole DKA process comes on. Brain can't get it. What it does is it tells the body they have problems. Give me sugar, give me sugar, give me sugar. And it'll start breaking down fat to produce ketones. The ketones, it can convert over to a form of sugar. Person's altered consciousness need to have blood sugar check level, which we know that. Opiates, used for pleasure and relief, depresses the body functions, work on the mu receptors of the body. And the whole thing that it does is actually activates the GABA side of the body. Okay, slows things down. We can smoke it, we can inject it, we can snort it, we can put it up the butt, we can inhale it, swallow it, all that stuff. Single dose, depending on what it is, anywhere from 3 to 6 hours. Over time, we do develop a dependency on it, which means we need more, and that's usually where the problems cause and all that stuff. So a whole bunch of different problems associated with it, even from other things like skin infections. So it might not be the opiate that's causing the problem. It's, they've been sticking the needle in the arm, and now they have endocarditis, which is causing the alteration. Uremia, all it is, urea is a waste product when we break down blood. The whole process, the only way that we can get rid of urea and all that stuff is through the kidneys. The early stuff, so we have anorexia, they don't feel well, they don't want to eat, and then they're actually having comas and loss. One of the pictures that you can have sometimes, if a patient, a renal failure patient, we pick those up so often from the Vitas or whatever. If they're altered, put your stethoscope on the heart and look and listen. Do they actually? Sometimes they'll have a friction rub. It's called a uremic rub, which is a good telltale sign. All right. Over halfway done. Trauma, head injuries, looking at epidural, subdurals. Epidural is pretty much the rapid. They get usually the middle cerebral artery is the one that has been damaged. This is the baseball bat to the side of the head, or the claw hammer that some people had happened. From there, they knock out, wake up, feel great, and then they go out again. And usually they can't come back. The subdural is more the insidious. This is damage to the bridging vessels, it's usually the veins. Slow bleeding. This is the person, the alcoholic, the older person that fell, several months ago and then has over time developed the slow bleedings and all that stuff. And then any other intracerebral hemorrhages, car accidents, gunshots to the head, stuff like that. Ruptured blood vessels with resulting swelling, edema, and all that stuff. And of course, we know trauma, shock, different stages of shock. Looking at pupillary sizes, right pupillary right side, left pupillary changes usually on the left side. And then, of course, always consider is it chronic, your alcoholics, elderly patients, and all that stuff. On the head injuries, always make sure you're taking the total picture of the patient, looking at decreased neurologic. Are they having any irregular breathing? Do they have lacerations, contusions to the head, any deformities? So if they have bilateral bruising to the eyes, what is that called? Raccoon eyes. Okay. And what is that an indication of? Okay. Central skull fracture. Yep. All right. And if they have bruising behind the ear, battle signs. All right. And that's what's that indicative of? Not so much spinal injury. It has the potential, yes. What type of skull fracture? Basilar skull fracture. Oh. All right. So bruising around the eyes, behind the ears, and all that stuff, nausea, vomiting, which are usually a very ominous early sign if they have real bad problems. So altered, and then they start nausea, vomiting is a real bad. And then you'll start getting into unequal pupil sizes. Seizures, more traditionally a late sign. It's a very ominous that there's really bad going on. And of course, always ask about the mechanism of injury. Did they go through the windshield 40 feet? Did they fall? So on pediatrics, the concern for falls is how much? Okay. Tumors, is it benign? Is it malignant? That's all I'm going to really talk about with the tumors. Not much more for you guys to do there. But an assessment for head traumas and all that stuff, again, histories, any surgery, chemotherapies, radiations, experimental treatments. Are they having any nausea, vomiting, weakness, double vision, seizures they haven't had before? So that's the AEIOU-T. The second I is going to be into the infection, meningitis, which is irritation, inflammation of the meninges or the covering of the brain, versus getting into the encephalitis. Meningitis usually bacterial, except in the except in the college age. That's where you start getting into more of the herpes simplex virus as a can mask patients, medical personal problems, and all that stuff. Urinary tract infections that we know is a cause of infection that causes alteration. We see this a lot of times in the elderly as one of the main causes. Pneumonia, either viral or bacterial, and then sepsis, which usually either the very young or the very old with the sepsis side. This is my son at the age of 1 day, actually 1 day out of the hospital, so 3 days old. We were in the hospital for 21 days, IV antibiotics, because we thought he had that, and then any brain abscesses, which I don't have any pictures for that. Poisonings, we know so much the poisonings can cause things. Drug overdoses, intentional. It's, get the full story. Mixing meds. Have you guys heard of the Skittle parties? So Skittle parties, they come dump everything into it and go from there. Is it accidental? The older person that wants to sleep can't sleep. They take some sleeping medicines, then they take some more, then they take some more, and then go from there. Young children, which we always know about with the potential problems getting into the parents' meds and all that stuff. The other P is your psychiatric. Are they schizophrenic? Are they depressed? Are they bipolar? Anything like that. So schizophrenia, you have the positive symptoms versus the negative symptoms versus the negative where they kind of sort of withdraw. They don't answer you. They don't talk. They're having some of the delusions. They're depressed. Versus the positive symptoms where they're flight of ideas. They're talking. They have tangential thoughts. They're very flamboyant and moving and all that stuff. Versus the bipolar. Periods of mania versus depression and all that stuff. All right. So AEIOU-TIP, and then getting into S. So strokes, seizures, and syncope. Stroke, we know, is any inadequate blood flow to the brain, usually either through a hemorrhagic or ischemic, which is the most common. Getting to more, you see more ischemics. All right. So time factor is critical, especially with the stroke patients, recognizing signs and all that stuff, which we'll talk about in the 7Ds of stroke care. And then looking at doing your Cincinnati stroke scale, the FAST and all that stuff. 7Ds, I'm going to detect signs and symptoms, dispatch, delivery, get EMS to the scene. Then from there, door to the ED, data, get all the tests that we need to decide, are we going to use the thrombolytics or not, and then any of the drugs. All right. Ideally, 3-hour time period, less than 3 hours. That's what all the literature says for that. Just like on a heart attack, someone's having a heart attack where it's door, they're now going, by the time that you guys show up to the time that they actually limit or see things, for heart attacks is 90 minutes. This is by the time that you guys show up to, we deliver the medication less than 3 hours. Or even from there, the symptoms, onset of the symptoms, 3 hours. Faster the better. Detection, 3 hours, we give medications. Again, anything that I ask for. If nothing more on the history on a stroke patient, if you were able to get from when did this start? All right. Get that, makes my life so much better. Right side of the brain, usually left side of the body, left side of the brain, right side of the body functioning. That day. All right. So on the seizures, usually it's just uncoordinated electrical activity. Signs and symptoms depending vary. Is this a generalized seizure versus a focal seizure? Generalized being the total body unresponsive, unconscious. And then the localized seizure just might be twitching an arm. If you guys remember going to the homunculus and all that stuff, you could just have a one part of the brain that could be affected. And that's seizures is a whole nother lecture, 2-hour lecture by itself. Really from the aspect of any head injuries, blood sugar problems, any increase in blood pressure and all that stuff. Fever always has potential problems. Hypertension and pregnancy, eclampsia, preeclampsia, remember that stuff? Then that's usually due to toxemia. Seizure types, grand mals, or the petites, absent mal, focal seizures, psychomotor, or the epilepsy, which is just, tonic-clonic. Correct. I didn't update this. It's absence, but he showed up the doctor. Grand mal or your tonic-clonic, sometimes you can have the or. Sometimes you can have orb preceding it. Sometimes they don't. They know convulsed total body. Usually with the tonic-clonic or grand mal with that. They have a generalized seizure with a postictal period. From there, the convulses is the tonic phase, which is the rigidity, versus the clonic phase, which is the rhythmic jerking, and all that stuff. And then the period of the postictal, and everyone's postictal phase, is can vary. There is a potential of having something called Todd's paralysis. It says it's hemiparalysis. I've usually seen it as a total paralysis and all that stuff. Yeah. Petit mal or your absent seizures, they usually don't lose posturals. More common in children versus adults, and they can have up to 100 a day. The most common is usually they kind of sort of stare off into space, or they blink their eyes, they twitch their eyes, and that's about the extent of it. So, man, those times when kids are like, not responding to school and all that stuff, and say, hey, yeah, my kid's just having an absence seizure. Focal motor seizures, rhythmic jerking of the arms, usually don't lead to consciousness, but a focal motor can lead to a generalized. So the shaking of the arm leads to that one side goes to the whole parietal or the whole lobe of the brain. So a very focal spot of the brain goes to a lobe of the brain, which in turn goes to the brain itself. Psychomotor, they kind of sort of think that it's could be psychotic in nature, meaning that they're doing it themselves. Some are just the smacking of the lips, the movements of the hands, and all that stuff. We just call them, psych patients, drunks, and all that stuff. All right. Treatment-wise, remove the patient, restrain them, roll them if need be, and again, avoid. For the EMTs and all that stuff, even simple intranasal, your Valiums or etc. like that. You need to get IVs in, get fluids, magnesium for the pregnant patients, and go from there. ABCs. And then it's usually the most common cause of death is the post-ictal airway loss. So they stop breathing. Give them oxygen. All right. We know, we've seen this. You can put a patient that's actually having an active seizure. You put them on pulse ox. Okay. They clench down. They stop breathing. Their pulse ox will dip. I mean, I've seen them into the 40s before. So, impressive at times. Again, get the history, any anti-seizure medication, vital signs. If they can ventilate, good. If not, ventilate. There's 2 seizures without intervening consciousness, or if the patient is still seizing and you arrive on scene, so a seizure more than 5 minutes or 2 without the patient returning back to baseline, that's status. All right. Immediate life threat, secure airways, transport, get ALS, and for you guys, what should you check? Sugar. Yep. Don't forget the sugar. Epilepsy just means to seize, possess, or afflict. This group of long-term is more neurologic symptoms. Not all patients that have epilepsy need to go to the hospital. All right? If they get back to normal, respond, okay, no problem. So those are one of those patients that you can actually call med control and potentially has a sign-off and go from there. Who did stroke? Who did seizures? Now syncope. Syncope just by definition a fainting spell, usually depending on what age group. More the elderly, it's cardiac induced. More the younger, it's usually dehydration, been out drinking, or you have the females that have the cardiogenic syncope. And all that stuff. Different warning signs: lightheaded, sweating, weakness, paler, just not feeling well. Assessment, like everything else, do either your 30 seconds or your 3 minutes, but don't forget about your cardiac assessment. Are they having arrhythmia? Do they have new AFib that they never had before? Are they in VTAC? So check with that. Management seems safe. Checks, support breathing, check sugar, all the typical stuff. IV fluids for the medics, advanced EMTs, and then cardiac monitor. Okay. Yes. All right. So on the home stretch. So a little bit on headaches, some dementia, deliriums, and finishing up with just a little psychosis. Different types of headaches. We know vascular types, migraines, versus cluster headaches. With the migraines throbbing, usually they have it's on the front, behind the eyes, right-sided, left-sided. Some people might have it in the occipital region. It is more common in women. Usually the aspect of treatment can be anything from simple usages of some nausea medications. Narcotics are usually a last resort because they can cause rebound headaches. Cluster headaches, more usually common in men, and it's the last 1 to 4 hours. Yes. Usually it's based in one place, and they're thinking now that a lot of migraine is actually might be a little focal seizure type piece. So that's why they're even using some of the anti-seizure medications for it. But yeah, it's usually typically in one spot. Some people do, it does vary, from side to side and all that stuff. Oxygen is actually the mainstay therapy for the cluster headaches. So really from there. The drooping of the eyelids and all that stuff, going from there. Tension headaches, this is usually stress. So the trapezius muscles get really tight, pull on the back of the head. We all get these frequently. And then any of the organic causes, tumors, infections, and all that stuff. Assessment, like everything else, when did it happen? When did it start? What were you doing? Severity of the headache. If you need to use the face pain scale or the 1 to 10, how long has it been going on? If it's been short time period, some of the medications we can get kind of sort of help out. Longer time periods, need to try something different and all that stuff. Everything else seems safe. IV if need be. Check blood sugar. Assess cardiac. And then any of the antiemetics and analgesics. So with the elderly, think about trauma falls. They're common for that, especially with the altered mental status. And then from there, are they having any heart arrhythmias? Are they having a heart attack? Atrial fib, V-fib, anything like that? Are they demented, which we'll talk about in a little bit? Any infections? We know that's a huge thing with altered mentals with the elderly. Medication. Did they get started on new medication? That's usually a cause for a lot of them. Shocks, sepsis, all that stuff. Any respiratory problems, and then from there the hypothermia. This time period now with cooling down, we'll start seeing some patients die because of that. And then sugar problems. They don't eat. We know that. So what's the definition of dementia? Confusion, okay. Sudden onset or progressive onset? Progressive, okay. So progressive disorientation, any confusion, anything like that. Causes different things, age, neurologic diseases, Alzheimer's, and all that. All right. So delirium, if dementia is progressive, delirium is sudden. All right. More sudden onset, and then from there again, it's the whole thing. So sudden onset, disorientation, all that stuff. So disorganized thinking, acute confusion, cognitive impairment, encephalopathies, or that's the quote unquote altered mental. All right. So looking at the difference, dementia is, of course, the chronic, slow progressive, irreversible. Usually they have impaired memory, global cognitive, versus the delirium, the rapid onset, can get reversed if we need to. Greatly impairs focal cognitives, chooses your toxicities, drugs, infections, all that stuff. All right. Some people can have, as we get delirium on top of dementia, or we can just have delirium by itself. This is the patient that's seeing things, that they're picking up things, and all that stuff. All right. So behavioral, combative, withdrawn. All right. So the behavioral, the combative patient, they're getting voice louder. They want to go at it. They want to have fun. Patient shouting. This is withdrawn, not having problems. They're not looking at you. They're kind of sort of withdrawn down and all that stuff. So on the combative, make sure try to use your I forgot what my brother calls the talking jujitsu or whatever. But yeah, your verbal jujitsu. All right, talk them down. Anything that you need to. Don't try to cause other problems. Really listen. Where should you be in comparison to the patient? Far away. Okay. Where else? What should be between? So the patient should never be. Yes. Yeah. Never between the patient should never be between you and the door and all that stuff. Provide calm, supportive care. Treat medical conditions. Don't argue with the patient. Don't confront them. Sometimes, though, if you need to, medications, the medics and all that stuff can take them down. Realistic insurance, and then respond. Haldol is a good thing. First aid, Benadryl, and all that stuff. Restraints, if need be, just remember on the guidelines. If you're going to take the patient down, try to take as many friends with you to get to do that. Nothing funnier than having some small girl, kicking everyone's butt because just how it is. Chemical restraints versus physical restraints all depends on what the guidelines saying on that side of things. Biggest thing is just make sure that you don't compromise any of their ability to breathe. So no hog tying, no sandwiching, no choke holds, no nothing like that. Now always document. Watch personal space, so the verbal de-escalation or your verbal jiu-jitsu, 1.5 to 4 feet, typical here in the United States. Keep your paper out, avoid contact if need be. Physical restraints, hard plastic ties, handcuffs, leathers, surgical mask if they're spitting and all that stuff. Don't transport in prone position. Remember the position of asphyxia. Be prepared to protect the patient's airway. Don't secure to the side straps to the rails. All right. We don't need the ambulance to tip over and the patient's still stuck to the cart and all that stuff. Sometimes you might need to put a towel or something across the knees. That helps them kicking. And then for the medics, this is a lot of times the aspect of why I like chemical restraining patients. So if they've been fighting for long periods of time, they can actually develop rhabdo, which leads to a renal failure, increase in potassium, and then they can go into dysrhythmias. And then don't leave them unintended. Chemical restraints, just for the medics and all that stuff. Pharmacologic, decrease agitation, increase cooperation, not to alter the level of consciousness, even though we know it does. Haldol benzos. For the medics, I've also included Benadryl into that, which is a wonderful thing. I call it 52. Yeah, 50 of Benadryl, 2 of Ativan, and 5 of Haldol. So my nurses at the hospital know. I'm like, give me a B52. They know. You can use diazepam, lorazepam, or any of your midazolam. Use the midazolam is the best one. All right. Any questions?